Okay, good afternoon, everyone. Welcome to this webinar, Addressing Workplace Violence in Healthcare, a collaborative model. This event is brought to you by Security Magazine, and it is sponsored by Everbridge, Hanwha, HID, HID-IAM, Milestone Systems, Salient Systems, and Security Information Systems. I'm your moderator. I'm Diane Ritchie, Editor-in-Chief of Security Magazine, and thank you, everyone, for joining us today. Today's presenters are from Mayo Clinic, Scott Levy, Senior Manager of Global Security, and Heather Gunn, Nursing Education Specialist of Education and Professional Development. We're going to just do a couple of quick reminders. One is to go ahead and submit your questions all throughout the program, because at the end, both Heather and Scott will address as many as possible. Now, we're going to have a few words from our sponsors. Everbridge's critical event management platform delivers organizational resilience for hospitals, combining real-time monitoring, situational awareness, and integrated response and collaboration from a single enterprise-wide view. Hanwha TechWinds devices automate alerts of abnormal events and remotely monitor high-risk patients. Visit hanwhasecurity.com for a trusted video surveillance solution in the healthcare industry. HID Global powers the trusted identities of the world's people, places, and things. Millions of people globally use HID products and services to navigate their everyday lives. For more information, visit hidglobal.com. Migrate workplace violence in healthcare with intelligent patient visitor management. Ensure the right people have the right access for the right reasons with HID Safe for Healthcare. Milestone Systems is a leading provider of open platform video management software, technology that helps the world see how to ensure safety, protect assets, and increase business efficiency. Salient is a leading manufacturer of video surveillance solutions designed to help deter crime and to give first responders actionable intelligence. Healthcare organizations trust Salient to deliver video security where it matters the most. Security Information Systems provides affordable and feature-rich software, offering a wide range of products, support, features, and capabilities. Want to learn more? Visit securitysoftware.com. Just a quick note there about the copyright materials, or the fact that this presentation is protected by U.S. and international copyright laws. And then next, I want to just give you information of the folks that want to get CEU credit. We are authorized to offer 1 CEU for this program. So participants completing this course may be eligible to receive that credit or CPEs toward ASIS recertification. So I'm required to read these learning objectives, and then we'll get on our way. The learning objectives for the presentation today are to describe acts of workplace violence in a healthcare setting and response plans to mitigate risk, to develop action plans for security and nursing professionals to prepare and respond to a workplace violence event, to identify healthcare standards and guidelines aimed at reducing workplace violence incidents, and to integrate the importance of communication of multiple teams to provide a rapid response. Thank you, everyone, as always, for being patient with us for those few housekeeping items. And now I will turn over the presentation to Scott and Heather.
Diane, thank you so much for that wonderful introduction. Again, I am Heather Gunn. I'm working as a nurse education specialist here at Mayo Clinic, Arizona, and I am here in support with Scott Levy, our Senior Manager of Global Security. We wanted to come and talk to you a bit today about the violence journey that we have been on here at Mayo Clinic, Arizona, and how the utilization of a collaborative model has really helped us in that journey. So we thought it would be nice to start with a quick historical perspective of Mayo Clinic here in Arizona. We lovingly refer to ourselves as the oasis in the desert. We're actually located here in Phoenix, Arizona, and for a while, the location that was selected for us was through an intended future of planning for a large-scale medical destination center. Up until this point, we are simply located on a large plot of desert with not too many people around us. This is actually engaged with our staff as we have been here is a little bit of geographical isolation. We have also, with our name as Mayo Clinic Arizona, been known as that destination hospital, and that has also led some of our community members not to seek care at our location, thinking of us more as a specialized location. From those standpoints, our staff over the last few years have really been sheltered in a way from violence within our community. We have a couple of level 1 trauma centers that handle a lot of the traumas and I would say drug-related issues. And we have some top-notch behavioral health centers here where those patients are being cared for. So in 2012, back in Rochester at our sister hospital, there was a large discussion related to violence and how to continue preparing our staff in managing violence in the workplace. Some of that discussion had started with some known legislation that was coming down that was going to start requiring organizations and hospitals to provide violence awareness education along with action plans to manage violence in the workplace. So as they began their discussions, they started pulling together groups from our Arizona location and our Florida location to look at our enterprise policy, some of our online education, and then filter out some of the rest of the decision making to be done at our state hospital locations. So here in Mayo Clinic, Arizona, we kind of began our discussions in 2014 and 2015, and born at that point was the collaboration model that we are about to present to you guys. So without further ado, I would like to present to you Scott Levy to talk about that journey and the things that we have initiated here at Mayo Clinic, Arizona.
Well, thank you, Heather, and thank you to Diane Ritchie and Security Magazine for hosting us today, to all of our sponsor partners. As Heather mentioned, I come from Chicago, and so when we talk about culture shock, I'll share a little bit of my own. Coming from running security at the University of Chicago Medical Center on the south side of Chicago, level 1 trauma center, previous to that, Sinai Health System, a level 1 trauma center on the west side, it wasn't unusual for us to see 8, 10, 12 traumas a day, double that on weekends, triple that on holidays, and everybody would come out. It wasn't unusual to see 50, 100, 200 people all claiming to be nearest and dearest family members. Everybody was a cousin in those circumstances. So to come from that environment in Chicago to lead security here at Mayo Clinic, Arizona, was a little bit of a cultural shock on several fronts. First of all, sitting here today, 75 degrees and sunny in the middle of winter is great for my Chicago soul. So to all my friends in the Midwest listening, hello. But also, just from a professional standpoint, what I had seen as over the course of my experience with our teams in Chicago at various locations, fairly significant violent events and the after effects of that. Part of the issue in managing security in a trauma center environment is you don't want your hospital to become a secondary place of violence. You don't want your location to be the spillover for any type of revenge, retaliation, finishing the job, or family dynamics, gang dynamics, et cetera, that would go into that. So looking here at Mayo Clinic, Arizona, as Heather outlined, really didn't have a lot of that type of exposure. We're not a trauma center. We don't have a large population from a women's health perspective outside of our emergency department. A lot of people come here from all over the world to seek care, and it may be their last best hope for a wide variety of illnesses, diseases, and whatnot. But tied to that is an open access emergency department that does allow any and everyone to come into our doors, and we see that increasingly be the case. So I think it's important to understand as we talk about workplace violence in the healthcare environment that we're only going to cover a few key points relative to what we have been working on here at Mayo Clinic, Arizona. We know as security practitioners that any comprehensive workplace violence plan in a hospital setting, you need to focus on gathering data. Data is one of the strongest tools that you can have, and trying to get accurate, useful data is always a battle in a very metric-centered organization like Mayo Clinic and many of the institutions represented by those on the call today. As security practitioners, we're always focused on what we call hardening the target, looking at the physical infrastructure. Are there doors that should be secure that are currently not? Is there better lighting required? Is the path or the flow of patients, visitors, distinct from that of staff? And if it is, how do we define that with an access credential, with ID badges and so forth? Security, we always want to increase security staffing. Everywhere I've worked, I've never wanted less. I think that we always are looking for a strategic, as part of our strategic plan, to increase security staffing and presence. And that sometimes runs contra to the patient and family-centered care philosophy that many of our institutions embrace. And so how does a stronger visible security presence run up against a patient and family-centered care model from that standpoint? We also want to look at enhancing healthcare security officer profile, things like uniform appearance, defensive weapons becoming more and more present within our healthcare security programs, training security and clinical personnel, and collaboration, reporting, and adjusting. So today, we're going to focus on a few of those, looking at connecting the dots on workplace violence. We're going to discuss understanding workplace violence in healthcare, what it is, and the nature of the problem at hand, the sources of workplace violence, training security personnel, educating clinical staff, forming and utilizing a workplace violence committee, and measuring, reporting, and adjusting key metrics and information to address and hopefully solve to this issue. As security practitioners, we understand the increasing epidemic of workplace violence in the healthcare environment. From 2002 to 2013, the rate of serious workplace violence incidents, those requiring days off for an injured worker to recuperate, was more than 4 times greater in healthcare than in private industry on average. In fact, healthcare accounts for nearly as many serious violent injuries as all other industries combined. So just by virtue of showing up to work, those who are choosing to work in a healthcare environment are at higher risk than most any other profession combined. It may surprise you to learn that guns and knives are not the biggest threat to healthcare workers, though of course we need to be prepared for active shooter and external threat situations. The most common causes of violent injuries resulting in days away from work across several healthcare occupations were hitting, kicking, beating, or shoving. So that means that every patient and visitor that comes into your hospital is coming in with weapons, fists and feet. Mayo Clinic is not immune. In Arizona, calls to security have gone up on average 42.3% per year over the past 4 years. We have seen assaults and threats go up year over year. The big issue is we don't know the full scope and scale of the problem. Why? Because these incidents are vastly underreported, both nationally and here at Mayo Clinic, Arizona. We need to instill that assaults and being threatened on the job are not part of the job. There's a culture within healthcare of silence toward violence. And it's not okay. It's not all right. And we need to make sure that our team members, our caregivers, our providers, our support staff are all familiar that A, it's not okay, and B, if something does happen, you need to report it to your supervisor, to security, to those who can help support those issues and those concerns. Here at Mayo Clinic, we have identified 3 groups that are responsible for the majority of the violence that we see, and 2 special categories of violence for awareness. The first group encompasses our patients. Most patients are not in the hospital for a happy reason, and many are highly stressed due to medical condition, cost of treatment, receiving bad news, and not getting information timely. Heather, you worked on the floor as a frontline caregiver. Can you share some of your experiences with dealing with patients and their family members?
I think you're hitting the nail on the head when you talk about our patient psychological standpoint when they come to us. There's a famous quote that from a nursing standpoint we often recount to ourselves, and what is just another day for us is actually a life-changing event for our patients. So when they come to us, I've had a lot of experience in surgical services, and we do a phenomenal job of prepping our patients and prepping their families to what that surgical experience will be like, from walking in the door and being admitted to what the wait time is, when they'll speak with the providers, and so on. And anytime we fail to meet those expectations that we ourselves laid out, it is just like that trigger, it's that spark. And these days, I will tell you that patients are much quicker to anger than they ever have been before. They don't accept the simple apologies. They don't accept the explanations for why things happen. They go from 0 to 100 in a moment and start making irrational demands and screaming and yelling and things of that nature. So definitely patients and their families and the things that they're going through are a huge source of violence, especially for those clinical bedside practitioners.
Well, and Heather, I think one of the things that you and I have been working very closely on in recent times has been education around patient restraints. It again was fairly unusual outside of the emergency room and perhaps in some of our more intensive care settings to look at and have to apply patient restraints and all the associated procedures that go with that, caring for the restraints, all of the clinical side of having to monitor patient vitals and documentation in the charts and all of that in the electronic medical record. But that's another nuance, because one of the challenges is that you often can't remove a patient immediately from the hospital. You can certainly expedite discharge if becomes a criminal element. They certainly could become a forensic patient until they are discharged and going into the custody of a law enforcement agency. But more often than not, that's one of the more challenging circumstances of dealing with patients. On the other hand, especially coming out of trauma environments, as I mentioned, we often said that it wasn't the patients themselves that were as much the issue, it was the people that came with them. In a trauma center environment, that was often the case because the patients were often incapacitated, but 300 people were showing up outside, and often unruly, from that standpoint. So when we talk about the second group of workplace violence in the hospital environment, that's the patient's family members and visitors. Violence can be triggered with a bad prognosis with a family member, poor family dynamics, negative interaction between family members and staff, and any type of visitor restriction which can provoke hostility. There's often legalities involved, particularly around patients who are not decisional or have mental capacity to provide their own medical decision. And so there often is elements of risk management, legal, security, and nursing working together to address those type of scenarios. But more often than not, you can and do often restrict visitation, whether it be for certain times, certain number of people at a time. Certain individuals cannot visit at all, whether it be for the duration of that patient's stay or for the duration of forever within our charting and within our systems. So we want to be mindful of the various challenges that family and visitors can portray within our healthcare environment. Heather, any thoughts on our family and visitors here?
No, I would say that I agree with you. They have an equal level of, if you want to call it a threat assessment, definitely that emotional bond that people have with their patients or with their family members as patients when they think they're not getting the care that they deserve. They are not shy in letting us know.
So let's turn to our third group, which is staff. Most common, we see staff-on-staff violence, usually escalating from bullying or verbal taunting among coworkers into more physical violence over time. So it's always important to get involved as early as possible from an HR and security standpoint. Another set of staff to be mindful of are terminated staff, those losing their job, especially those who are terminated for cause or violence. Security should work hand in hand with human resources to be engaged for any potentially hard terminations. We do that as a matter of policy here at Mayo Clinic Arizona. It should also be standard protocol for terminated employees to be informed both verbally and in writing that they are not allowed on hospital premises for anything other than their own emergency medical needs. The federal EMTALA law requires that anyone who shows up to an emergency department be given a medical evaluation and treated before they can be discharged, regardless of whatever history they may have with the institution. However, we can and often do restrict visitation for any other purpose for those who are terminated for cause, particularly for workplace violence or other anger issues or things of that nature, and make sure that people know that both at the time of termination, both verbally and in writing. A couple key situations I'd like to point out as outlined here on the slide. First being domestic violence. I often tell our hospital staff that the rules of civil society don't end at our hospital doors. What I mean by that is that if something is threatening you outside our walls, it can easily threaten you inside our walls as well. This most often is demonstrated in staff members engaged in hostile personal relationships that include verbal and physical abuse, domestic violence. It's important for hospital security to be apprised of any current domestic threats to staff, such as a bad divorce, court orders of protection, etc. Security should provide accommodations, such as escorts to and from parking areas to employees going through these types of issues, and other accommodations to support our employees who are going through these very challenging situations. I always make it a point for employees that are going through those types of situations to ensure that we have copies of any orders of protection or court enforceable documents, specifically if they do list our hospital, our workplace locations as a restricted location. That's going to be very useful if and when the occasion presents where that husband, wife, boyfriend, girlfriend, ex-husband, ex-wife, whatever it may be, does present themselves, and you have a legal standing to prevent them from gaining further access to your premises, and in fact to be trespassed and taken into police custody if they do present. Lastly, I'll mention external threats. This is the least common in the hospital environment. It's not very often that we have random criminal wandering by the hospital and decide, hey, I'm going to go cause trouble in there, but it can occur. We all should be mindful and prepared for active shooter and other external threats. Regularly testing your lockdown and emergency response protocols helps to keep staff sharp. Now that we've identified what violence is and where it is most likely to come from, we need to ensure that our staff are prepared to handle violent situations as they occur. So let's turn to our definition of violence and ask the question, do you have one? And Mayo Clinic does. Mayo Clinic has a workplace violence policy, which says, in part, quote, threats, threatening behavior, acts of violence, or any related conduct which disrupts work performance or Mayo Clinic's ability to carry out its mission will not be tolerated. If your organization does not have a clear definition of what constitutes violence, you need to get one. I shared Mayo Clinic Arizona's definition of violence, including both physical and verbal acts and threats, which are defined even further in our policy, workplace violence, through the use of examples. Workplace violence is defined as both acts of violence and threats of violence. Acts include the use of weapons of any kind and any unwanted physical attack, such as hitting, pushing, or throwing objects. Threats include any expression, including speech, conduct, email, social media, or other written messaging designed to frighten, terrorize, or otherwise place a person in fear of bodily injury. Defining what violence is helps to establish a common language and pushes against the culture of silence that we spoke of earlier. Having a policy is really only step one. Once you have a policy in place, it should not be a secret. It should not be something that's hidden from staff or even from the public for that matter. It's important to promote your policy on workplace violence to staff so that they're familiar with what it is and is not allowed, and what to do when something bad occurs, or even the potential for something bad occurring. When the hairs on the back of the neck are standing up because the brother of this patient is giving you, verbal threats or taunting or things of that nature, we need to be able to immediately turn to our resources and how to address that. We're proponents of signage in public areas, demonstrating a zero tolerance for violence and ensuring that the public and our patients are aware that Mayo Clinic does and will prosecute for any violations of criminal law and remove you from our premises. Mayo Clinic also supports staff who want to pursue criminal charges, and this is the key point. Any hospital, Mayo Clinic or any institution, cannot itself press criminal charges against an individual. Mayo Clinic as an institution, the security department most often, can represent the hospital for crimes against the property, typically trespassing or theft. In a violent situation, the complainant needs to be the victim or victims of that situation. And that may well include a patient, a family member, or a staff member. Mayo Clinic itself or any institution cannot be the complainant in a criminal charge, a criminal complaint against an individual. We often will support those type situations with additional charges of criminal trespass or disturbing the peace or something of that nature as need be. But something that we emphasize to our staff through all of our workplace violence training is that they themselves, A, are empowered, and B, should and will be supported in pressing criminal charges as need be if the law is broken against them and they are a victim of assault, battery, or any other criminal act, and that the institution will support them to the full extent through our various resources. So something that we wanted to do here at Mayo Clinic was to promote violence prevention through staff awareness and vigilance. And here at Mayo Clinic Arizona, our security team regularly promotes the concept from Homeland Security, if you see something, say something. I think this is familiar with many of us on the call. We wanted to take it a step further and find a creative way to recognize staff members who report suspicious activity to security. What we came up with was a Mayo Clinic Security t-shirt. You see it here. With the message, I saw something, I said something, I got the t-shirt. One recent example. There was a career thief hitting area hospitals here in Phoenix, stealing whatever he could get his hands on from open office areas, shoes, laptop computers, wallets, and more. After his first known visit to Mayo Clinic, Arizona, we were able to pull his photo from video footage. We shared his photo with both security and desk staff across the hospital as a BOLO, a be on the lookout for. During his next visit, he was recognized by two frontline desk staff in one of our outpatient clinic areas. He was walking in and out of offices, poking around, looking for things to steal. I should note that he always presented in a very professional appearance, suit and tie, briefcase, and looked the part of someone that was in a medical office environment. One desk assistant kept an eye on him while the other called security. Our security team was able to apprehend the thief, and he was arrested by Phoenix police. This stopped a fairly significant theft wave impacting area hospitals. We presented the t-shirts that you see there to the employees at our quarterly managers and supervisors forum meeting with hospital leadership. They have become collector's items and generate a lot of interest in our security awareness program. So I share that with you as just one of many things that we've done as part of our violence awareness, security awareness programming. As someone, again, to take it to that step further, tokens of recognition, tokens of appreciation for those who are there. And to that end, whenever I get up in front of any audience here at Mayo Clinic, Arizona, one of the things that I often begin my remarks with is asking the question, how many people do you think work in hospital security? 20, 30, 50, 100? People will guess various numbers. And the reality is 7,000. And that's the number of employees that work at Mayo Clinic, Arizona that carry a Mayo Clinic ID badge. Everyone that carries a Mayo Clinic ID badge is deputized as part of our security program and part of our safety awareness planning. So to that end, that's part of our overall approach, and we go from that standpoint. So before we continue our discussion here, let me ask our first poll question. On a scale of 0 to 10, with 0 being not prepared at all and 10 being completely prepared, how prepared do you feel to deal with a violent individual? Please rate your answers on the survey in front of you, and we'll give you a moment to do that. All right, so we're starting to see the poll results come in. Let me click over to the results. Let's get those last responses in. All right, so we see here, sounds like a lot of good preparation, trending toward the upper 7, 8, 9, 10 echelon, heading in that direction, which I would expect from many of those on the call. So thank you for your responses. Stay ready. We have some more questions coming toward you in just a moment. But let's talk about security training. Over more than 15 years in security, I've developed and utilized many different training programs, both off the shelf and self, home created, so to speak. As another sign of the scope of workplace violence as an epidemic, there are many more off-the-shelf programs for verbal de-escalation, self-defense, security competencies, and more. Many of the programs that are out there are very good, Evade, Moab, Team from HSS, and many others. But you need to find or create the training programs that best meet your needs. I'm sharing with you here a number of the different programs that we use, not as an advertisement for them. I get nothing for this from them, but wanted to share with you just to give you a little bit of a picture as to what we do here at Mayo Clinic. Our goal at Mayo Clinic Security is to have the best trained, most professional healthcare security team in the industry. Training and professional development in both formal and informal settings is key to what we do every day. Here are just some of the training programs we offer through our Mayo Clinic Security Academy. Basic training and the field training record. All new officers at Mayo Clinic Global Security go through a rigorous basic training program outlining both enterprise policies and local or site expectations and procedures. Each officer is assigned a field training officer who ensures completion of the field training record document, demonstrating all the competencies necessary for success. Report writing. All of our officers across Mayo Clinic Global Security complete comprehensive report writing training. This ensures accuracy and thoroughness of security incident reports and helps our staff in understanding that these incident reports are legal documents, often used by law enforcement and prosecutors in building cases against subjects. We utilize the IEHSS 3-tier certification program from the International Association for Healthcare Security and Safety. This establishes a baseline foundation of security knowledge focused on the unique challenges of the healthcare environment, such as patient restraints, missing valuables, trespassing, and more. This training provides credentials for our personnel, which are valuable to their career development, such as the CHSO, Certified Healthcare Security Officer, CAHSO, Certified Advanced Healthcare Security Officer, CHSS, the Certified Healthcare Security Supervisor, and the CHPA, Certified Healthcare Protection Administrator. One of the main programs that we utilize for our de-escalation and violence intervention programs is CPI. We tell our officers that the strongest tools on their tool belt is their voice. To that end, verbal de-escalation skills are critical. All of our personnel complete the 8-hour certification nonviolent intervention training from Crisis Prevention Institute, CPI. CPI combines both verbal de-escalation as well as physical intervention skills, such as how to respond to wrist grabs, chokeholds, and other defensive tactics. HDTS. We supplement the skills learned in CPI with more hands-on self-defense and handcuff certification through the Healthcare Defensive Tactics System. In addition, all of our officers are certified annually in CPR, AED, and first aid, as they may be first responder to a medical emergency situation. Similarly, we recently introduced Stop the Bleed training for all personnel, and all officers carry tourniquets on their duty belts at all times. Let me turn it back over to Heather to discuss how we began to transition educating not just security staff, but our clinical personnel as well.
So thank you, Scott, very much. I love the fact of when you're asked of how many people are on your security team, that we get that number of 7,000 back, because that's kind of how this collaboration began, is security really thinking outside of the box and what it takes to prepare an organization to identify violence and be prepared to manage it. Because what we're trying to do is we're trying to give all of our staff the tools that we had for many years been giving to our security staff, especially when it comes to de-escalation. So back in 2014, the beginning of 2015 is when those questions really began. How do we start training the staff members outside of our main security department to be prepared? So one of the first steps on that track was to enlist the help of an outside vendor through the CPI training that security was already receiving. The one difference that we utilized here at Mayo Clinic Arizona was CPI, or those outside vendors, typically offer one of their own vendor members to come in and teach your staff at your organization. Mayo Clinic decided to invest the time and the finance to send our own staff members to CPI to become instructors themselves. What we felt that this did was actually bring back the tools of the de-escalation process, but then be able to discuss some of the individual issues that we were dealing with here at Mayo Clinic Arizona as well. So the violence awareness courses that we brought back included the full 8-hour certification course. This course was deemed mandatory for all of our ED staff members, as well as it already was for our security members. And then we also recommended, or highly recommended, that certification course for team leaders, our patient care technicians or nursing assistants, and anybody that was in that leadership role on the unit. We then introduced a non-certified course, which was 3 hours in length, that still discussed some of the key concepts of de-escalation, managing patient behaviors, without going to the full extent of the physical skills that CPI was going through. Later on, we began to discuss that Mayo Clinic Arizona is a very unique and diverse group of staff members and a lot of different areas in which we practice. I think a lot of times we get hung up on an inpatient idea of a hospital system, but here we have multiple outpatient areas, surgical services, both inpatient and outpatient, small little primary care areas. So we really wanted to look at unit-specific education and began creating content that could be utilized in a lot of different avenues. I have had security personnel go and teach at a 30-minute luncheon, to the point of both myself and a security team member going to a full 3-hour session in a professional development days. I know that hearing back from our leadership staff that that's one of their favorite things about our program is they can still get that content to their staff members regardless of how much time they have to spare. We also focused on some of our leadership buy-in and attending those leadership meetings. We felt that it was extremely important to bring the leadership staff into the violence discussion, where we could really talk about why the topic was so important to their staff members. And we typically did this by going on what we like to call road shows, where we would have members from risk management and from security head into those leadership areas and really have an open dialogue about the importance of violence awareness and how to prepare our staff. Finally, we incorporated large-scale interdisciplinary education. We actually just had a large-scale event in February where we brought together members of security, nursing education, risk management, quality, and even our chaplain services to come and talk about violence in healthcare, the effects of violence, not only from a physical or emotional standpoint, but even the effects that it can have on your spirituality and your desire to come back and take care of the public. In all, the amount of time that we have spent through our educational process has really opened our eyes to the extent of violence in general. So before we move on to our next subject, we wanted to ask a quick question related to your outlook and how many eyes you have looking at your violence issues. So does your organization currently have a dedicated workplace violence committee?
We'll give you a few moments to answer this poll question, see the responses start to come in. Interestingly, we are equally divided, 50-50 as of this moment with the poll question. Does your organization currently have a dedicated workplace violence committee? I think if you haven't gotten the point yet, Heather and I strongly recommend that as one of the major takeaways, a workplace violence committee is a good collaborative place to start, and that's what we're going to talk about as we move into our next slide here.
So as things began here at Mayo Clinic, Arizona, it really was a joint effort between security and nursing education. We were hitting a lot of staff members, a lot of different areas, but we knew that we needed to get the lens a little bit broader than it was. So we created this violence prevention team using staff members from a variety of disciplines, as well as representatives from risk management, quality, informatics, administration, care management, public affairs, and chaplain services, to name just a few. We certainly had those bedside staff members in from a few of our high-risk areas to ensure that the ideas were transferable to the bedside. Some of the functions of this committee included the collection and reporting of workplace violence metrics. These metrics included the number of occurrences, of course, but we also recorded data related to the individuals involved in the incident, whether or not an injury occurred, and the possible reason for the event, such as post-anesthesia confusion. When our committee reviews the data, they are typically working to discover trends, locate hotspots, and identify areas of concern. These discoveries assist with our security and our leadership partners to make decisions that we know will eventually benefit the organization. Decisions related to security rounding and staffing requirements have been directly influenced by the data review of this company or of this committee. We also do incident case reviews. We will typically have a member of security bring to us an incident that had happened, where we can then discuss the incident, look at it through those different lenses, really break down what happened, and possibly come up with solutions to prevent the incidents from happening in the future. Finally, our Violence Awareness Committee works together to develop the tools necessary to increase staff awareness. These tools can include everything from the on-site courses, which I mentioned earlier, to flyers, e-signage, and computer documentation. It truly is a team effort that then uses the expertise of all involved to disseminate information that has been created to the individuals that need it. Scott, anything to add about that collaborative effort?
Absolutely, and Heather, I think, gave a great summary. This, to me, is the key to the whole thing. And really, the genesis for our hosting this webinar today was focused on what we're doing here can certainly be a model for different organizations. It's agnostic, it's not Mayo specific, of gathering the key parties that are working together or should be working together in a collaborative way across departments, across silos, really to identify and try to remediate and mitigate the risks that are presented from these different incidents and violent occurrences. The partnership between security, nursing, providers, risk management, and others is crucial to keeping the spotlight both on the problem itself of workplace violence, never forgetting that it's out there, and all of the things that we're collectively doing to address that. I'll share a quick example of a recent case that we've been dealing with in the past few days here in Arizona. Dealing with a long-term patient who has been admitted to the hospital since early January, which is a long-term stay in a hospital setting. Part of the challenge with this patient is his diagnosis, multiple diagnoses, and what are called comorbidities. He has several different things going on, including that he's autistic, that he has several different medical conditions, all of which in combination make it difficult to place him in a safe environment where he can be properly cared for and treated. He is not decisional. He has a parent who is a medical decision maker, but she has also presented herself as something of a barrier to his care here in the hospital setting. Over the course of this patient's stay, there have been more than 25 unique incident reports generated due to violent incidents from this patient. And in the course of that, we have generated a lot of security and other interventions to this patient. And because of his multiple conditions, there are certain things that we typically would do, such as physical restraints and other measures that are either difficult or impossible, or if utilized, could potentially negatively impact the patient's well-being in that circumstance. Part of the challenge, as I mentioned, was and remains the patient's caregiver, parent, who has alternated between over-involvement, being an obstruction to care, and then disappearing for large periods of time. And in between, the patient continues to have violent outbursts, hitting staff, pinching staff, constant exposure of himself, sexual pleasuring of himself, and other issues of that nature, which have provoked a large swath of burnout, of staff injury, staff harm within that unit. So we have continued to take measures to mitigate that risk. But I think the key point for our discussion today is that we brought together through our Workplace Violence Committee that cohort, that collaborative team that recognized our pattern of behavior over multiple different reporting streams to really pull this together and get all the key players in a room over a series of different meetings to address the ongoing issues presented here, including the legal issues of conservatorship and guardianship present with this patient, and can the hospital take additional measures to ensure the safety and security both of the patient himself primarily, but also of staff and those surrounding the environment. That wouldn't have been as possible, or certainly not quickly as possible, in previous times when this type of collaboration that we're discussing didn't exist. And so to that end, we'll wrap up talking about measuring, reporting, and adjusting. Heather shared the vital importance of establishing and refining clear metrics for violent events such as threats, assaults, law enforcement, involvement, and more. And if there's one thing that Heather and I can leave you with this afternoon, it's this: what gets measured gets done. As we dug into our incident reporting, we realized that we had two main issues. First, that we had an issue of no reporting or underreporting of violent incidents. We mentioned several times that culture of silence that exists here as it exists in many hospitals across the country. The second issue we had is too many ways to report violent incidents, sort of the flip side of that coin. At Mayo Clinic, we have an electronic incident reporting system tied into our medical record. We have security incident reports. We have occupational health reports if an employee gets injured. We have patient experience reports. The patients or their family members themselves can go to our patient experience office to share their concerns. And these are some of the main channels of reporting, among others. So the question became, how do we pull these multiple streams together to get a better holistic picture? While we have not yet fully solved this problem technologically, the ideal solution would have one reporting mechanism or at least one collection portal from those multiple sources. We have developed some good workarounds. Working through our Violence Prevention and Mitigation Committee, we created a process to reconcile all the various reports on a weekly basis, providing more accurate and complete data on incidents. Our quality team then washes all the data for accuracy, compiling a master report and associated graphs that are reported out to hospital leadership. Taking this information and represented on one of the graphs you see in front of you, which is one of our actual charts, we can track and trend in pretty close to real time the different circumstances and trending going on throughout our house, throughout our hospital, across the board, and can identify, as we did in this instance, that with this patient case I mentioned, that we had more than 25 unique incident reports dealing with this one patient. And we were able to reconcile that and identify this and make our plans moving forward. So measuring, reporting, and adjusting are key measures to that end. So as we wrap up here, I'd like to just reflect again on our learning objectives that we shared today, describing acts of workplace violence in a healthcare setting, response plans to mitigate risk, develop action plans for security and nursing professionals to prepare and respond to workplace violence events, identify healthcare standards and guidelines aimed at reducing workplace violence, and integrate the importance of communication of multiple teams to provide a rapid response. I'd like to thank all of you for attending today's session. Heather and I look forward to continuing our discussion in the time remaining, answering your questions. And with that, let me turn it back over to Diane.
Thank you both. Outstanding presentation, and we have a ton of questions. Before I get started, just want to remind everyone, continue to send them for the next 9 minutes that we have here. We're not going to get to all of them, but I know that that both of our presenters are going to answer them offline. So let me just ask a couple of them that came in. Are you able to discuss how you're including law enforcement in your committees?
Yeah, so law enforcement is an active partner at all of our Mayo Clinic locations, and that's actually expanding. In Rochester, Minnesota, we actually are now utilizing what we're calling a hospital resource officer, an HRO, similar to a school resource officer that you're familiar with. This is a dedicated Rochester police officer within our hospital environment 24/7, and we're expanding that into our other locations, including here in Arizona. So we work very collaboratively with law enforcement on a daily basis or an as-needed basis for day-to-day incidents, and have a very strong relationship with command staff as to any ongoing issues, both here within our institution as well as neighborhood and community local business issues that could impact Mayo Clinic.
Okay. And speaking of that, one question came in about body cameras. Is that a technology that you might consider using, or are you using it?
Our security teams currently do not utilize body cameras. That's something that I think many institutions, including ours, are exploring as this technology is being adopted. We currently do not utilize body cameras. We do, however, have a wide array of CCTV, security cameras, thousands of them, located throughout our various hospital and clinic locations that we use for a wide variety of purposes.
Okay. I liked the comment that you made about, the fact that just because you're entering a hospital doesn't mean that your personal problems, stay outside of those hospital doors, that people, but just the fact of life, things come inside. So one question came in is like, what if you have a situation where a husband and wife work together and they're also in a violent physical or verbal situation at home? I mean, do you have any advice on how your team might address that situation with nursing and security staff?
Yeah, unfortunately, we have had that situation here and other places where I've worked. And here in Mayo Clinic, Arizona, part of the challenge there is we need to be able to identify who, or if both are, the aggrieved parties, or both are the victims, or one or the other. Because we've had situations where it was one or the other. We've had situations where it was both had counterclaims and both were physically abusive, et cetera. Where there are legally binding restrictions in place, that's why it's important for staff to self-report this by policy. It needs to be supported by policy, so that security teams and HR can enforce those situations. We have had situations where spouses or those in a domestic relationship were working in the same department, even in the same workspace. So those needed to change. We've had situations where staff have had to change shifts, for example, so they wouldn't be present on premises at the same time. In some cases, we've had situations where we had to restrict, one of the individuals could work on our Phoenix campus while the other could be on the Scottsdale campus. In some cases, because of the criminal nature of the charges and convictions, that became the source of termination of employment. In some cases, because of felony charges and so forth. So it really depends on the circumstances. But I think that being an active partner and being visible to all of your employees as a resource to that end, it shouldn't be something that's blasted on bulletin boards or put out there on Front Street, so to speak. But it should be something that is shared amongst your security teams, your security leadership, your HR leadership, to be able to work together to address those type of circumstances.
We only have time for one last question, but there have been a couple of questions that have come in relating to like specifically how you got executive buy-in for conducting drills during prime time business hours. Another question is, how did you get the financial buy-in for the CPI training? Can you address just a little bit about how you've had how you got that support and also the financial support for some of these programs?
I know a lot of that began back in Rochester when legislation was coming down about the need to have that required education. I know in Rochester we have a very large behavioral health center, They have a resource team that responds to any behavioral health altercation that happens. And again, I think it goes back to that collaborative discussion between your educators, your security, and that leadership to really have an open and honest discussion about the what if. What if we don't do something? What if we don't prepare them to a specific level? And really looking at what your risk factor is when it comes to violence. I know that money talks, and when you start talking about the financial implications of somebody getting seriously hurt, then you can parlay that into the money that you're spending on that preventative structure.
Okay, that's all the time we had for today. I want to thank Scott and Heather for their presentation. Also, a special thanks to our sponsors, Everbridge, Hanwha, HID, IAM, Milestone Systems, Salient Systems, and Security Information Systems. I'm going to make sure that both of our presenters get all the questions that were not answered today to hopefully be able to address them offline. I also want to just remind everyone we're going to archive this for a year on our website, and so you can watch it again later, also invite friends. And that's about it. Thank you, everyone, and enjoy the rest of your day.